Good evening, everyone. On behalf of the LAM Foundation, it is my pleasure to welcome you to this evening's LAMposium in Your Living Room educational webinar series. My name is Cindy Beasley, and I am the Director of Education and Advocacy for the LAM Foundation, and I will be your moderator this evening. For those of you joining us for the first time, a special welcome. To learn more about this educational series or to view recordings of previous presentations, be sure to check out our LAMposium in Your Living Room video series on the Foundation's website. And as you heard earlier, this evening's presentation will be recorded. So before we get started, I would like to take a moment to recognize and thank our generous sponsor, the National Disease Research Interchange, or NDRI. For those of you unfamiliar with NDRI, it is a not-for-profit organization with over 40 years of experience in supporting the advancement of biomedical research through providing human organs and tissues from a diverse pool of donors. Their partnership with the LAM Foundation and LAM patients has pushed forward the science of LAM through procurement of tissue at the time of transplant. We appreciate their ongoing support in our research and educational efforts. So, a few quick technical items. Microphones will be muted and the chat box disabled throughout our presentation. Once the presentation is completed, we will open up that chat box where you can go ahead and input questions. Following the Q&A, we will then move into a patient and family group discussion. And I encourage you to stay logged on for this opportunity to connect with fellow LAM community members from across the globe. That portion of the evening will not be recorded. And finally, for optimal viewing, I would suggest that you select the speaker view option for the presentation, then switch to the gallery view for our group discussion. So we have a fantastic program for you this evening. We are going to welcome Dr. Mary Beth Brown and Claire Child from the University of Washington, Seattle. They're going to share with us their research on the effects of exercise for women with LAM, along with the launch of their exciting new home-based exercise program and app called LAMFit. So allow me to introduce them. Dr. Brown is an associate professor in the Department of Rehabilitation Medicine Division of Physical Therapy at the University of Washington, Seattle. She earned her doctorate in applied physiology at the Georgia Institute of Technology and was a postdoctoral fellow in Indiana University's Pulmonary and Critical Care Medicine program. Her recent research focuses on exercise responses in pulmonary vascular disease and interstitial lung disease. Dr. Brown's sensitivity to the needs of LAM patients as it relates to exercise and fatigue resulted in an innovative study and publication regarding the health benefits of exercise for women with LAM. This groundbreaking research ultimately led to the development of the LAMFit digital fitness program. Claire Child is a physical therapist and a teaching associate in the Department of Rehabilitation Medicine at the University of Washington, Seattle. She is an American Board of Physical Therapy Specialties certified clinical specialist in cardiovascular and pulmonary physical therapy with clinical interest in advanced heart-lung diseases and cardiovascular, pulmonary, and oncology rehabilitation. Claire has over 10 years of clinical experience in large urban academic medical centers and critical care settings. Her research interests include helping patients with LAM and other interstitial lung diseases to safely participate in exercise as part of their health management. So it is my pleasure to now turn this evening's presentation over to both Dr. Brown and Claire. Thank you both.
Thank you so much. Can you hear me? All right, I just need to share my screen here with you, so let me do that. All right, now can you see my slides? Okay. Thank you for having me. I am so excited to get to talk to this group. I always am excited to talk to the LAM community, and it's even more exciting when I have great news to share and exciting things on the horizon. So we will begin this program with just a quick intro into what our outline will look like tonight. So I'll begin with just a little introduction and a kind of an origin story on the background of this work. And then my part will really just to share information about results from our first phase study, our LAM exercise and fatigue study. And then I'm going to turn it over to Claire Child, who will be talking about what most of you are here for, which is to hear about the upcoming LAMFit program. So, and then of course we'll finish with questions and answers. So let's get going. And I want to apologize up front for any of you who were at the LAMposium in your living room in December of 2021 at the international conference this past September, so in September of 22 in Chicago, or at the most recent Seattle regional conference meeting, because I shared a lot of these results and some of this history and sort of origin story there. So some of it will be a repeat for some of you, but bear with me. And one thing I don't get tired about talking about, and I'm going to tell you again, even if you've heard me say it 100 times, is the reason we study exercise in LAM is because we need to understand exercise in every person. Every single individual should be doing regular physical activity. And this is not just because we think it might be good, but because we know there's very solid evidence base for health benefits with regular physical activity. And I won't read all of these to you, but these are all the things listed on the CDC website in their physical activity guidelines for Americans that have strong evidence base behind them for benefits of regular physical activity. So take a second to look at that list. And these are all things that all of us as human beings are at risk for. So this is a great thing to introduce. I believe this session is why we're even talking about exercise. And then I like this figure as well, and some of you have seen this before, just showing you this relationship between how much sitting time individuals have and then how much moderate to vigorous physical activity they get. And it shows your risk for all-cause mortality, that relationship. Getting into the green is a lower risk for mortality, and into the red is a higher risk. So you can see that you can get into that red if you have high daily sitting time, which many of us do with our work and other responsibilities. But then as we do an overlay of moderate to vigorous physical activity, we can still obtain those protection benefits. So again, this is why we're talking about it. And I think we need to always keep that forefront. And then in terms of the history, the origin story really began for me back in 2017, where I was asked to come and participate in the exercise and fatigue workshop that the LAM Foundation was putting on as part of their patient benefit series of workshops. And these were all areas that patients said they were interested in learning more about and understanding more about. And it was determined at that meeting that we really needed more research concerning exercise in LAM. And we even had, a sticky board with all different suggestions that patients put up and providers put up. And from that, we put together a proposal to the LAM Foundation to study exercise. And it wasn't that exercise wasn't studied at all in LAM. There was actually a beautiful trial published in 2016 looking at the effects of pulmonary rehab in patients with LAM. And this was a controlled clinical trial. And in that controlled clinical trial, they showed really great benefit from the exercise intervention, the pulmonary rehab intervention. And you can see those listed here. What I want to point out to you, though, importantly, is that in that clinical trial, they were studying the intervention of pulmonary rehabilitation. So the structured center-based pulmonary rehabilitation program. And we were really interested in what was the possibility that we could get these same benefits, but approach it from a home-based type of intervention. So with home-based intervention, we're really talking about home-based aerobic exercise and home-based resistance exercise. And we questioned, could we get these same benefits, and proposed this to the LAM Foundation. And they funded this as part of one of their patient benefit research grant awards. So very much appreciate that support from the LAM Foundation and allowed us to start this journey. The title of that study was Mobile Health to Increase Patient Accessibility to Exercise and Elucidate elucidate exercise and fatigue in LAM. And I got 2 pointers. Do you see 2 laser pointers there or just 1? Maybe you just see 1. Just 1. Okay. On my screen, it shows 2. All right. So in that study, we prescribed a 12-week home-based exercise program with health monitoring. And that health monitoring was with spirometry that was Bluetooth connected so that we could see that data each week, a Fitbit, an activity monitor, heart rate monitor, medical grade pulse oximetry, as well as some data that patients would log. And then the intervention primarily consisted of an aerobic training program 4 times a week, as well as a resistance training program a couple times a week. And all of this were exercises that could be done in the home, mostly walking is the aerobic component. Nothing that required any specialized equipment, and nothing that required any center-based intervention. There were only 2 visits, a baseline visit and a final visit at day 90. So after that 12-week intervention. And we published the results of that study, and I just recently, and I'm not going to spend very much time talking about it right now, other than just to kind of give you the highlights, but I want to refer you to the published paper if you're interested in reading it. We enrolled 15 patients, and 14 of those completed. 1 didn't complete for reasons that weren't related to the study. You can see their baseline characteristics, their mean age, and their time since diagnosis. 2 had TSC LAM. 2 patients were using supplemental oxygen just with exercise. And then you could see their FEV 1% predicted there as an average. And so as I present this data briefly to you, I just want to kind of present it in terms of things that patients generally ask first, in terms of results or in terms of exercise. So one of the questions I hear is we know there's fatigue complaints in LAM. Is participating in exercise going to make me even more tired? And that's a very reasonable question. And I would want to know that as well. So one of the things that we did in this study is have people track their daily fatigue with a rating between 0 and 4 for every single day of that entire 12-week period. And what I want to point out to you is that no, at least according to this, patients did not get more fatigued from participating in a daily exercise program, despite the fact that they were exercising almost every day. And over that 12 weeks, they were gradually increasing that training volume, about a 52% increase in total training volume over that time. And in fact, not only did exercise appear to not make people more tired, it may even make individuals less tired. And we say that because we used 2 different standardized fatigue surveys in this study. One called a multidimensional fatigue inventory, and the other one a standard fatigue scales. And we assessed this before and after. And so the bar that's the gray is before, so baseline, and then the striped bars in this presentation will be the after. And then you can see in this in these 2 graphs that most individuals, and the individual data is shown as individual lines, dots with lines, and you can see that they had a significant improvement in that fatigue on both of these scales, pre versus post. So that was exciting to see. And then, oops, there we go. And then in addition to individuals having less fatigue on those standardized surveys, we also assessed quality of life using some standard psychometric indicators. Some of you may have completed this one called the ATAC LAM. And we saw in both of these assessing quality of life that we had improvements in visual analog scale, improvement in quality of life pre to post training. And then on the ATAC LAM, lower scores are better quality of life. So those also improved significantly, which was great to see. Individuals with LAM also ask if exercise might make them even more short of breath. Is that going to be something that they're going to notice, and that will be an adverse kind of response? And so what we respond to that question is no, at least not according to our data, because we assessed shortness of breath on an everyday basis as well. So when they were filling out fatigue scores, they also filled out their shortness of breath scores. And over 12 weeks, every day, these ratings, despite a 52% increase in training volume, we didn't see that shortness of breath or dyspnea go up. Did the exercise program improve lung function? Important question, right? And the answer to that is probably not, in terms of changing the actual disease process in the lungs. And we say that because when we look at pulmonary function tests before versus after, and again, before is in the dark gray line, and then the after is in the striped lines, we saw that most individuals stayed pretty steady in those pulmonary function tests that you're familiar with, as well as in what's called a maximal aerobic capacity test. Some of you may have done this if you've gone out to the NIH or in other labs or pulmonary function testing, where you do a maximal exertion. In our case, we did this on the treadmill, and we collect expired gases to determine VO2 max, maximal aerobic capacity. And you can see that that also stayed about the same for most individuals. So this maximal aerobic capacity in most individuals with LAM and that were in our study were limited by lung function, and without an improvement in lung function, we wouldn't expect to see an improvement in VO2 max. So then you come to the question of, well, what's in it for me if my lung function doesn't improve? And I did demonstrate to you already improvement in quality of life, really important. So despite fatigue or despite LAM, improvement in quality of life perception, as well as I showed you some evidence for reduced fatigue. So these are also demonstrated to be popular responses in other individuals with chronic lung disease in response to exercise training programs. And then the other two aspects that are important improvements that we saw with the exercise intervention was improved exercise tolerance and improved muscular function. And I want to show you those two results right now. So the improved exercise tolerance, what we're looking at here with the 6-minute walk test, and I suspect everybody here in this meeting has performed almost all of you, and maybe you do them very regularly with your care team. And the 6-minute walk test is a great test for submaximal exercise tolerance or submaximal exercise performance, meaning the type of exertion that you might do during a regular exercise program or during even activities of daily living, you know, climbing upstairs and vacuuming your house and going to the grocery store and those kinds of things. And so it's a really good picture of sort of the really functional exercise capacity. And what we saw in individuals pre to post training intervention is that there was a really nice improvement on almost all individuals, and a very statistically significant improvement for the whole group in that 6-minute walk test distance. And in the absence of lung function, you wonder, well, why did that improve then? And the reason for that improvement is because exercise intolerance and even the fatigue that we see is not just a consequence of the disease LAM. There's a really important contribution from musculoskeletal factors in LAM, actually in all individuals that are exercising submaximally and maximally. So this component can't be ignored, and this is what we suspect probably contributed to a lot of that improvement in the 6-minute walk test. And we investigated that by looking at changes in muscular performance using computerized dynamometry. And our computerized dynamometry, as well as some functional tests, specifically looked at muscular force, muscular power, and muscular endurance. And what we saw was a really nice improvement as mean change from baseline to final in especially the tests related to muscular endurance. And this makes sense because the training intervention really was mostly an aerobic training exercise program, what that really targeted. Even our resistance exercises targeted a lot of muscular endurance type activities. So this made sense that this improved, and likely explains a lot of the improvement that we saw with fatigue and with 6-minute walk test. And then the last thing I'll say about this study is that very important to me, and also important to Claire, is that we can test the feasibility of this type of program. This remotely monitored program needed to have solid feasibility to be scaled up to the next level. And this feasibility really depended on remote monitoring in a home-based approach working, even for individuals that have exercise-induced oxygen desaturation. And this is important because this actually, believe it or not, has not been studied in individuals with chronic lung disease. A home-based approach, remotely monitored for chronic lung disease, specifically with exercise-induced desaturation. And exercise-induced desaturation is very common in LAM, in the chronic lung disease of LAM, more than other chronic lung diseases. So we really wanted to make sure that this was solid and that we felt good about how we were monitoring this. So I'll give you just a quick snapshot of how we did this. So patients that were participants in this study were wearing medical grade pulse oximeters, as you can see pictured here, during every single workout, every single aerobic workout. And so this is an example of a single subject's 30-minute workout session one day. And it shows this 30-minute workout with the data that's collected second by second for oxygen saturation, shown in the blue line, and then in the red line shows heart rate. And so as you might expect, as the exertion goes up in this individual, and many of you may experience this, you see your oxygen saturation numbers drop down if you're an individual that does experience exercise-induced oxygen desaturation. And so what we were interested in was figuring out a way to present this in a meaningful data, both for ourselves, but also for patients. And so we did what's called a frequency analysis to really make this sort of a pie graph type snapshot where we can see how much of a single exercise session, how much of that pie was spent in no desaturation, so greater than 95% SpO2, or a little bit of desaturation shown in the pale pink saturation, so between 84 and 89% SpO2 in the purple, and then more severe, less than 83% there in the light blue. And this particular pie is shown for this exact workout right here. We made a pie graph like this for every single workout, every single week of the entire 12-week period. And we could sum that data both for every patient that participated as well as the group and look at, as a group, how did their amount of desaturation look in the first month compared to the second month, compared to the third month. And what we saw overall is that individuals commonly desaturate, these participants with LAM commonly desaturate during exercise, as we expect. Most of them, though, were only in mild desaturation. So about 60% of the time in this mild desaturation range, from 90 to 95% SpO2. So majority of the time spent there. And then the rest of the exercise session time for most individuals was almost split evenly between no desaturation or in moderate desaturation. And the other interesting thing to pull from this graph is that stayed pretty steady through the 3 months. And without a change in lung disease, without a change in lung function, we really wouldn't expect these to change over time. So this was good to see that there was no decrement in this, which we didn't expect there to be, and it did stay pretty steady. So that's all the data I'm going to tell you about tonight, because I don't want to take up any more of this time. But I do want to refer you to the paper where you can read in much more detail the findings from the study. There's one more paper that's going to be coming, at least one more, coming out of this study. And the next one, we're writing it now, and it's going to focus on the muscle changes, because we did some muscle biopsies in this study as well. So I'll present those at another time. But this paper is just out. And if you're wondering how to get it, a really easy thing to do is just go to your browser and type in this number, and you can write this down now if it's easy for you to just scratch it down. Just type in your browser box PMID 376-40274. If you type that in to the search box, hit enter, it's going to bring up this National Library of Medicine page that has this paper. And then if you just click on this link, we made this paper open access, meaning that anybody can access it without paying for it. And you click on that, and then you'll have the whole paper. So that is all I will tell you. And what I want to do now is turn this over again to what everybody is here for, I'm sure, is to hear about the phase 2 study, LAMFit. And Claire Child, who is, as you've already heard, a board certified clinical specialist in cardiovascular and pulmonary physical therapy. She's also works in on our faculty in rehabilitation medicine. But importantly, I want to point out she is on the home stretch, might be too early to say that, of her PhD in my lab. And I couldn't be luckier to have somebody as amazing as Claire working in the lab, and really is spearheading this LAMFit project. So it's so exciting to get to allow her the opportunity to talk about this now. So I'm going to turn it over to you, Claire. Do you want to just share screen?
Yeah, let me do that. Thank you so much.
Stop share then.
Introduction, and hopefully you can see my screen now. Can you see my screen?
Yes.
Wonderful. All right. Well, thanks for that great introduction, Dr. Brown. And I have the privilege now of talking about the next phase of the study, which many of you have probably heard about, and that's why you're here. And so I'd like to formally introduce LAMFit, which is the phase 2 portion of the earlier phase 1 study, where we will focus more on development of a program to expand access now to the health benefits of exercise for more individuals living with LAM. And as a little bit of background, I do want to talk about, in addition to some of the specific community needs that Dr. Brown and others have identified as early as 2017, really with the innovative LAM community, that there's also some discussion in the field of pulmonary rehabilitation about a need for a significant change for the way that things are being done, and really with the COVID-19 pandemic expediting the transformation of some aspects of healthcare. So pulmonary rehabilitation, center-based pulmonary rehabilitation, is traditionally a comprehensive multimodality type of intervention that is evidence-based and has primarily been shown to increase exercise capacity, help control dyspnea, and prevent hospital readmissions in chronic respiratory diseases, especially with the literature based mostly in COPD. But unfortunately, it's been historically underutilized, with less than 5% of eligible patients participating in pulmonary rehabilitation. So newer alternative models of what's called telerehabilitation and home-based models, like the one that we were able to pilot in phase 1, may help to increase access and adherence to pulmonary rehabilitation and structured exercise training. And as Dr. Brown mentioned, one of the things that we need to think about is the unique risk for exercise-induced oxygen desaturation in LAM. As a little bit further background, there's a digital transformation of healthcare that is well underway. And in the most recent Pew Research Center survey, which is a large independent research organization that does a lot of phone calls for more population-based screening, the vast majority of Americans, 97%, now own a cell phone of some kind. And the share of Americans that own a smartphone is 85%, and that's up from 35% with the first survey of smartphone ownership that was conducted by the Pew Research Center in 2011. So this level of smartphone penetrance really motivates the development of digital health interventions, like the one that we'll be using in LAMFit, that can be used for health promotion and risk reduction. So where our LAMFit program is going to fall is really in more of the health and wellness, the remote patient monitoring, and the care support domain of digital health, with potential for extension into digital diagnostics and digital therapeutics, which are being talked about more and more with the use of artificial intelligence, AI, and machine learning. And as you heard from Dr. Brown in her recap of the phase 1 study that's been completed and was quite successful, we are really excited now to think about how to expand the intervention, the evidence that we were able to bring to the evidence base for LAM, and expand that exercise intervention now to more people with LAM. And I do want to highlight again here that we've had some really exciting program achievements, accomplishments that I'm excited to share with you all. One being this great logo that we just really love, the LAMFit logo. And thank you to many of you, or some of you on this call that might have contributed some of your input into finalizing the logo. And so we really like it. And so thank you for everybody that's helped with that. So again, we emphasize in phase 2 here that this is going to be really about expanding access to the exercise intervention. So here's what our proposed protocol will be. And it may be a little bit difficult for you to see, but I do just briefly want to go through that there are some new features to LAMFit phase 2 that were not in the phase 1 study. So first of all, we know that, especially in the pulmonary rehabilitation literature, that when patients finish pulmonary rehabilitation, it can be difficult to continue exercise after cessation of the program. And that may be the case for some that participated in the phase 1 study as well. It's human nature. It's a challenge to keep things going outside of a structured program where there's maybe some accountability. So traditionally in pulmonary rehabilitation, often patients will transition to a maintenance type of a program. But we think that with a home-based and a digital health-enabled type of a program, that we can actually ask participants to start another 12-week exercise program shortly thereafter to continue the exercise prescription that's recommended and that we know is beneficial. So LAMFit will be a two subsequent 12-week home exercise programs together. It will be delivered on an entirely digital health remote monitoring platform. And we will conduct a baseline, a midpoint, and a final remote study visit or digitally enabled study visit using surveys, activity monitoring, all sorts of neat, fun digital health monitoring types of to share this with you. There's also some unique aspects that we're also adding that were not part of phase 1, and those are included here at the bottom. We're also going to be sending reminder prompts to you using the app and facilitating a Team LAMFit social connection type of a website where there can be some additional community engagement. We think that will be really helpful. So in order to make sure that this type of a phase 2 scaled up platform can be successful, one of the things that we really thought a lot about as a study team is how to optimize the safety of a remote approach or a unsupervised home approach that you are going to be continuing to have pulse oximetry monitoring, but it's going to be what's considered asynchronous. So there's not a real-time healthcare professional that is able to view the data and help you make decisions about that. So it's asynchronously monitored. So how can patients with LAM be medically pre-screened for appropriateness to participate in this type of a program? Because of the challenge of how geographically spread out participants are going to be, this is a really important first step. And so I'm really excited to share with you some of the outcomes of the AIM-1 part of the study that we've already completed. And our AIM-1 was to create an expert consensus LAM-specific exercise pre-participation screening tool, really that is designed for pre-screening prior to LAMFit, but has really generated a lot of helpful information and guidance for all individuals with LAM that are interested in participating in an exercise training program. So to conduct the AIM-1 study, we used what's called a Delphi panel study methodology, and it was a modified style of this methodology, modified approach with round 1 as an online survey that was sent both to patients with LAM and also LAM professionals, both medical providers, researchers, clinicians in the LAM community. And then a round 2 in-person meeting of LAM expert professionals, which occurred at the May 2023 American Thoracic Society conference. So I'm happy to share some of the results of these surveys and how they're informing our next steps with LAMFit. So first of all, thank you to many of you that perhaps are on this meeting that completed the round 1 survey of individuals with LAM. We had 60 people participate, and the mean age you can see is relatively similar to the phase 1 mean age of participants, and but also I think some additional insights because we had a larger sample for this survey. And the questions that we asked were really around what are the perceived risks associated with exercise, specifically according to the lived experience of people with LAM. And we asked some more specific questions about oxygen during exercise, pulse oximetry monitoring, some common concerns about pneumothorax potentially occurring during exercise or what to do after an experience of pneumothorax, and other health complications during exercise. And I can share some of these results with you. So this is the patient report of fears or concerns. And about 40% of respondents said that they do have some concerns present about oxygen desaturation during exercise. And then 27.5% were concerned about their pulse oximeters not detecting desaturation. And also other concerns about health complications, pneumothorax, not insignificant. So at least 20% of respondents were concerned about these things. And then wearing oxygen during exercise, some people reported some challenges related to this. So we felt that these are actionable items that we can bring to the experts in how we think about considering risks and minimizing risks during a remote, home-based, unsupervised type of a program. And then for round 1, where we administered the online survey, we also asked an expert panel of LAM care providers. And these are all the participants that we invited to fill out a survey. And I want to present side by side some of the exercise-related fears or concerns according to individuals with LAM, which we just talked about. And you can see that there were similar concerns present for oxygen desaturation during exercise. LAM care providers expressed a little more concern of pneumothorax during exercise, 60%. LAM care providers did discuss specifically something called syncope or fainting during exercise and other cardiovascular events, and felt that was especially important to screen for. They also shared concerns for pulmonary hypertension, both resting pulmonary hypertension as something to screen for, and also exercise-induced pulmonary hypertension. And then falls and risk for falls being screened for prior to initiation of a home-based program. I do want to add though, we asked a question to both groups of stakeholders here. Do you have fears and concerns related to exercising remotely in your home, or for patients to exercise remotely in their homes without the direct supervision of a physician or another exercise professional? And more than 80% of both groups said that they did not have concerns. No, they did not have concerns. So this is exciting to us. I think it is supported by the literature as well that says that the benefits of exercise outweigh the risks. And for most people living with cardiovascular and pulmonary conditions or other chronic but stable conditions, unsupervised exercise carries a very, very small amount of risk. We also asked the LAM care providers what were some of the best practices for screening for risks. And you can see those here. I want to highlight that both in the round 1 and then in the round 2 in-person meeting, that care providers felt it was very important for a baseline a clinical exercise test to be completed for people living with LAM to know if they need oxygen during exercise, because we know that's part of the living with the condition, but also that they have adequate amount of oxygen and they know how to adjust their oxygen prior to initiating a home exercise program. Oh, okay, sorry. All right, so then we had this in-person round 2 meeting of LAM care providers, researchers and clinicians and other stakeholders. And it was a wonderful meeting, a breakfast meeting, and we all got together. We talked about the results of the first round of surveys, and we had some rich discussion about how to develop a pre-screening tool. And I'm happy to present that we have come up with a consensus, expert consensus, LAM-specific exercise pre-participation screening tool, we're calling it. It's a big mouthful, but essentially a tool to help LAM care providers to screen people living with LAM for appropriateness to enroll in LAMFit and other remote or home-based exercise programming. And I want to go through this just very briefly with you. This is going to be a screening step for enrollment prior to LAMFit, a very important one. We think that this is an essential tool. We've thought a lot about it because it's different. This phase of the study is going to be different than phase 1. Phase 1, we were able to conduct a baseline study visit and get to know each participant. And when we're scaling up a program, an exercise program, as much as we want to, we don't have the time and the resources right now to fly you all here to Seattle and to do this. But we think and we know that you likely have a very close relationship with your own LAM care provider, whether it be a primary care physician or a pulmonologist or somebody at a LAM Center for Excellence. And so they are going to know you and be able to work with you on making sure that you're safe to participate in an exercise program. This is also consistent with best practice for really any other chronic and stable condition that people live with, and it's widely recommended. So prior to enrollment in the LAMFit program, we are going to ask interested participants to get screened by their LAM care provider as an in-person screening. And their LAM care provider would then be able to tell if they have a known history of cardiovascular disease or not, and use a tool. It's called the AACVPR, or the American Association of Cardiovascular and Pulmonary Rehabilitation stratification algorithm for risk of cardiovascular event. And to think about, do interested participants have a risk for a cardiovascular event during exercise? If they do, then they can use that tool to stratify the level of risk, and if needed, refer to either further testing or a center-based type of an option. If there is known history of cardiovascular disease, we do still recommend, and again, this is the expert consensus recommendation, performance of a clinical exercise test with pulse oximetry, such as a 6-minute walk test or whatever other recommended exercise test, standardized exercise test your care provider recommends. And again, that will be helpful for pre-screening for oxygen need during exercise. And then proceeding down to the next step here in the pre-screening tool, that based on each of the different risks that were identified by patients and experts in the Delphi study, there are some other things to screen for. So as I mentioned, cardiovascular risk. If a patient is a higher risk of cardiovascular event during exercise, it's likely indicated for them to have more of a center-based outpatient rehabilitation approach with real-time monitoring. Pulmonary risk was discussed, and it was felt that individuals that have experienced a pneumothorax in the last 4 weeks should wait to exercise until their pneumothorax has resolved and they've received medical clearance by their provider. Other things under pulmonary risk, if if a person with LAM does have severe pulmonary hypertension, resting pulmonary hypertension, they are recommended for an outpatient rehabilitation approach. And that is, again, consistent with the current best practice for pulmonary hypertension. For risk for falls, this is one that we think is going to be best determined or again, because we can't assess all participants in person by the care provider. So if there's no risk for fall, then that person is likely indicated for LAMFit. If there is a risk for falls, then I think it's really between the care provider and the patient to identify what's the best option. And then something else that is a little bit more difficult to truly quantify is whether one's home environment is conducive to exercise, and also if technology use is feasible. And so that's something that the person can talk to their care provider as well. All right, so we do plan to launch LAMFit as a 6-month pilot study. And our goal is for this program to launch on January 1st of the new year. And we're making progress towards that. And so we're excited to share some of the eligibility here with you. So you may be eligible for this program if you do have a diagnosis of LAM, you're 18 years or older, you are in stable medical condition without any major treatment changes or medication changes in the last 3 months, and you are able and willing to participate in a home exercise program. As I mentioned, our program will include a baseline, midpoint, and final assessments. There will be 2 12-week home exercise programs with a heart rate guided exercise prescription, and all participants will be asked to use digital health monitoring. And here's an overview of the program timeline as well. And I'm excited to also officially launch today something that we have been working hard on, the LAMFit website. So this is now live. You can go there and you can see it and check it out and read more about the study. We really thank a lot of people in the community that have shared some of your wonderful photos with us. Thank you so much. And we've been working with a graphic designer and a website designer to make this a really great website. So go check it out. The website address is www.lamfit.org, and it has more information about what to expect. Sorry, went too far. Okay, and so we will be, for those that are participating, we will be giving a free Garmin wrist wearable activity monitor. We'll be using medical grade pulse oximeters again, and we're working with some digital health platform administrators to administer a specific app that allows us to accomplish all of the parts that we've been talking about. If you are interested in participating in LAMFit, you can go on to the website. And again, after reading about a little bit more about the website, there is a survey that you can, an interest form that you can fill out. So, so please do think about it and let us know if you are interested in participating in the next phase of the study, which is LAMFit. And Dr. Brown and we want to acknowledge that all of this work we've done, this journey that we've taken, the story that we've shared is not possible without all of you, without patients and study subjects, our University of Washington, funding from the LAM Foundation, and we just thank you. And also huge shout out to Allie, I can never say your last name, Vino Gopal, sorry, who's helped us all along as a real collaborator. And thank you so much to the rest of you who have been part of our studies to date. And now we can open it up for any questions.
Cool, thank you, both Dr. Brown and Claire. This has been amazing. So I'm very excited to hear what questions are out there. At this point, we will open up the chat box. So feel free to type in your questions there. We will read those and then present them to our speakers. So I'm going to start with a few questions that were submitted to us in advance of the webinar. So the first one is, we have a woman who's a little older that has LAM. She's over 70 years old, and she's wondering whether LAMFit is really for all ages.
Yeah, thank you. What a great question. Thank you very much. We have thought very carefully about this, and we very much do not want to make it age discriminatory. So we don't have an upper age limit. It is going to be limited to people over the age of 18 and also living in the United States for the next 6 months of the pilot study. So that would be really something to discuss with your LAM care provider on if there's any other reasons why you wouldn't be able to participate, but there's no upper age limit.
Great. And is there any, go ahead. Mm-hmm. Can
I just add one other detail I didn't mention? We are going to ask your LAM care provider to attest that they've seen you within the last 3 months. And so it's very important. We think that you should have a in-person checkup with your LAM care provider and that 6-minute walk test or other exercise tests within the last 3 months.
Great, good to know. And at this point, there will be no cost to it, correct, based on what you presented to us today? Okay, great.
Yes, at this point, there's no cost to it. We have funding to support 25 participants in our pilot study, and we do have the goal of eventually making it eligible, increasing the eligibility and enrollment to all people with LAM that are medically appropriate to participate.
Great. Okay. And then somebody had asked you whether pregnancy is taken into consideration. So it sounds like you're going to track symptoms over time. What happens if you get pregnant in between that time before it's over? So.
Yeah, thank you. That's a great question as well, and thank you for asking it. Because of the ethical review board process that we've gone through for the pilot study, we will not be enrolling participants who are currently pregnant. That's a self-report. And if we do find out, or if you find out that you've become pregnant during the study, then please do share that with us. And again, it's not meant to be discriminatory. It's more just for the purposes of our review, our internal ethical review process at this point.
Great. I have a question from the chat box. Somebody was asking if they are post-transplant. Can they enroll in the study as well?
It is unfortunately one of our exclusion criteria for right now. But again, in the next phase, when we expand this larger, we will consider those other still affiliated with the LAM community populations. We're trying to, again, from a scientific design approach, have the ability to make some broader statements about the community, the population of LAM. And so we are seeking a geographically representative population or participant pool. So we will be thinking about things like where you live, disease severity, time of diagnosis, activity level. So those are things that we'll be thinking about as well when we select the 25 initial participants.
Wonderful. And somebody did ask if there was a maximum lung function requirement. For example, would you have to have mild LAM in this initial phase then? Do you have any parameters around that you're looking at?
We do not. No, we don't have any parameters for severity of LAM. The only thing that we have as an expert group thought about is the pulmonary hypertension risk. So if you have severe resting pulmonary hypertension, then you're going to likely be indicated more for a center-based pulmonary rehabilitation approach. Okay. And again, this is a program that's going to not replace center-based rehabilitation, but we think that it's another strategy to increase access.
Sure.
So a clear distinction we're making as much as we can.
And then anyone's pulmonologist or physician can make this determination, right? It does not have to be a LAM clinic doctor. Is that correct?
Yes.
Okay.
Yes. It needs to be a primary care provider, and that can be somebody with an MD, a DO, or a nurse practitioner.
Great. All right. And are there any restrictions for patients currently taking sirolimus or everolimus? Are you tracking that or?
No limitations, yes, and we will ask you about your medications that you're on, but that's not a reason to be excluded.
Okay, great. Another question that was submitted earlier, I noticed you had a slide up that talked about the FEV1 and the FVC and the VO2. Somebody was asking about DLCO, whether you saw any changes in it with exercise.
We did not measure DLCO in the LAM exercise study. We weren't equipped to be able to do that at the center where we were doing testing. We have since conducted, or actually just completed, a randomized controlled trial of a similar intervention in another interstitial lung disease called idiopathic pulmonary fibrosis, IPF. Some of you may have heard of that. And we did actually get all equipped to study DLCO because we recognize it's an important pulmonary function endpoint. But in this first phase study, we didn't have the resources to collect that.
Makes sense. Yeah. And then someone is asking about, this actually came from a physician that was wondering if there were any LAM patient subsets in which the type of exercise program that you're recommending is contraindicated or something that they shouldn't do. Have you looked that deeply into it at this point?
Another great question. I think our phase 1 study was 15 participants, so we can draw conclusions from those 15 participants. In the expert consensus panel, we really drew upon all the clinical expertise, the research expertise that was there in the room. And because out in the literature, there's a smaller amount of evidence to support those types of development of precautions or contraindications. And again, based on what is available and then the expert input from people in that Delphi study, the primary risk groups were those experiencing pulmonary hypertension, those experiencing recent pneumothorax, but not necessarily other concerns about disease severity, even oxygen desaturation during exercise. Those things, if the participant has adequate oxygen availability and has been seen by their own provider, the risk is likely very low for adverse.
And then will you be monitoring PFTs at all during this time?
We will not do center-based pulmonary function tests, but we will be asking participants to do home spirometry, similar to the phase 1 study. Okay. And that will be at baseline, midpoint, and final, not weekly. So it will be part of the remote monitors that you receive if you participate.
Great. And I have quite a few questions coming in. People's wheels are turning right now and thinking about, will they be seen by their pulmonologist before January 1st? And there are several who are saying they will not, and that it's difficult to get in. So there's some questions out there about whether your date for January 1st is a hard date, or whether some people can start at different times, or just people are curious how you're going to approach that.
Yeah, thank you for that great question. We know it's hard to get in, especially around the holidays, and everybody is trying to see their doctors and get things done before the end of the year. So we understand that. So if you have seen your provider within the last 3 months and you have completed a clinical exercise test, then that data can be used and your provider can make a recommendation to us for you to enroll. If you have not, ideally try to get in as soon as you can. It will be a rolling enrollment, so we know that it's going to be hard for everybody to be screened before January 1st, but we hope to at least start the intervention, and then as people are able to enroll, that we can continue that.
Great. And then there's some questions around too, the actual fitness program itself. So is this something that you are going to, in essence, prescribe to people, or could people use their Orange Theory or other programs that they use to participate in this?
Yeah, great question. So similar to the phase 1 intervention, we will request that you complete at least 30 minutes. I think in phase 1 it was 45 minutes, but at least 30 minutes for this phase 2, 4 times a week. And we will provide a heart rate recommendation for at least a minimum threshold. Again, trying to get at the moderate to vigorous intensity levels. We have a lot of literature to support that that's beneficial for cardiovascular, muscle performance, other benefits. So we will recommend at least 30 minutes per exercise session, intentional exercise session, 4 times a week. And instead of in phase 1, you had somebody from our team reaching out, checking in regularly. We will use more of a digital approach with messaging, and in the app, you'll be able to see your progress as well.
And then I've got several questions here too. People are very excited about this program. Some of them are overseas, some are in Canada. We've got some who are saying, I know I'm not going to qualify right now. Is there a timeline or just thoughts on how this will be developed for people outside of the US and outside of the tight parameters right now?
Yes. Thank you for your interest. And this is something that is difficult, I think, for the pilot study to limit to just the United States. Beyond that, we fully intend to expand access to outside of the United States. There are some additional challenges with that, and for the purposes of this pilot study, where, and I think we pointed this out, but just to emphasize again, we're adding in a couple of more new components. We're doing digital or remote testing, some different approaches that we want to study in a controlled way to show if they're effective and feasible. And then we'll look forward to expanding outside of the United States.
Great. And then someone is asking, have you been able to determine an optimal heart rate range in connection to desaturation in participations in the first LAMFit study?
I was just typing out a way.
Is that right? An answer? Okay, that was a great question.
No, it's okay. I'll just say what I was typing out. So I'm glad you asked that. You're probably going to be sorry you asked it, because this is a topic that's near and dear to me, and I get on my soapbox. But we really, in chronic lung disease in general, we don't have a good evidence base to be able to say this is exactly the number you should be shooting for related to oxygen saturation, and this is what how your heart rate range should be adjusted. That data does not exist, and so we are in the great situation right now, having conducted 2 exercise studies where we've collected heart rate and oxygen saturation second by second during a 12-week intervention in 2 populations that desaturate, LAM and IPF. And so with that data, we're spending a good bit of time now. It's actually one of Claire's PhD dissertation aims, actually, to better understand what that data can tell us about the exercise prescription, the optimal exercise prescription. How do you factor in the desaturation and any other factors that go into figuring that range? So right now, our approach, we're using this based on what is available. But as I said, this data that we're collecting, and we collected it in the previous 2 studies, and all of you that participate in LAMFit and in the next, the pilot, and then also the follow-up, that data is going to be rich data to inform this research question, because that's really what we need, are numbers, to be able to have the power to make some conclusions related to this, because it's such an important question. So absolutely, yeah. So thank you to everybody who is patient with a little bit of the ambiguity there on that, but know that it is definitely my mission and Claire's mission to get some more answers for you.
Love that. And then there's, of course, there's the full-on exercise, and then we have things like breath work that we do, right? Or that's available to people. And so there are a couple of questions around that, whether it's of any benefit for LAM patients to do breath work, or are there any techniques, exercises, or methods of breath work that should be avoided in a LAM patient? Have you all seen any of that in your work?
So it's interesting, the person that asked that question actually looked into breath work when that question was emailed to me several months ago, and I kind of dove into what available literature there was, and there's not any really related to chronic lung disease and lung, in lung function and the effect of breath work. But there is a growing database suggesting that breath work can help control movement. And breath work, for those of you who don't know, it's really a practice of deliberate control of breath. And there's different protocols that can be used. But there's a growing body of evidence supporting that it could be effective, especially for improving stress and mental health, usefulness in mental health and mental health disorders, anxiety, those kinds of things. But I am happy to see there's a clinical trial underway that's investigating feasibility in at least one patient population. It's in a chronic low back pain population. So we don't have the evidence for LAM, definitely. We don't have it for specific patient populations. And the evidence for breath work is challenged mostly by the fact that what's published now is it's not been investigated in isolation. It's often included in other mind-body focused wellness interventions, like yoga, which is great, but then it's difficult to ascribe cause and effect, right? So, one interesting aspect, I think, to me is the possible usefulness in LAM in maybe helping to reduce dynamic hyperinflation, which can occur in LAM and can impair ventilation during exertion. But like I said, that is just off the cuff, and it's not, it's nothing that has research behind it yet. So I think the exciting aspect of LAMFit is not just what we have prepared to start with as the LAMFit program, but what could be later incorporated into it. Things
Sure.
like, potentially breath work, things like mental health sort of strategies, things like pelvic floor health. I'm helping with a study of pelvic floor health in women with LAM right now. So, things like that are all possibilities down the road, not this initial pilot, but down the road.
Right. It seems like the possibilities are endless, which is very
Really
exciting, right? I mean, there's so many different avenues to take here.
Yep.
So we have quite a few women who are asking questions in terms of enrollment with specific issues for themselves. So on the website itself, will there be a place for people to really kind of tap into that with those types of questions? They're wanting to enroll, or how would it be best for them to get those questions answered, I guess is my question.
Yeah, so there is, if you have questions prior to filling out an interest form and some clarification details, there is a study email that we've set up. It's I can put it in the chat. It's LAMFit-study@uw.edu, and we can try to share some of our some of the at least the guidelines. I think we do want to help people make a informed decision on whether they want to enroll, but we do have limitations in our capacity. So maybe give the really specific question, that'll be really helpful as we can try to get that information back to you. So I'll put that into the chat.
Great. And then just as a final question, because I know you all need to roll here. And this may go back to what Dr. Brown was sharing earlier in terms of we're just gaining knowledge as we go, but they're wondering about how do they keep their fitness at peak performance? And I guess particularly for us as women with LAM, right, is that going to vary from woman to woman, or is there like we can read guidelines about peak performance if we don't have a chronic lung disease, but is that ultimately a place where we'll be able to go, or do you all envision this kind of as an individualized peak performance monitor, if you will, in the future?
So the question is,
how do you maintain peak performance?
How to maintain peak performance? Yeah. So this is really what we would consider more of a prevention type of approach, and it is about maintaining or improving your own ability to, of course, to perform aerobic types of tasks, but also to maintain fitness for your activities of your daily life, whatever those specific goals are for you. And so that falls in kind of prevention work, what would be termed like secondary prevention. And so, yeah, I think that there is the potential for maintaining and improving your own aerobic fitness And then the specific goals related to aspects of your life that you want to keep your peak activity level. Those are going to be related to your own goals, what you want to get out of the program.
Right.
That hopefully LAMFit can help you with. And those are important to us. So we will ask you about those.
Wonderful. Great. Well, thank you all so much. This has been so informative and engaging. I clearly that our chat box blew up, so we've got a lot of excitement. I will be reviewing the chat box. I know, Dr. Brown, you were wonderful about trying to get some of those questions answered specifically in the box as fast as you could.
Yeah.
So for those that didn't get their questions specifically answered, I will review those and forward those to Dr. Brown and Claire, and we'll do our best to get those answered for you in the future. I can tell you without a doubt that practical applications for improving quality of life is a consistent request from LAM patients when it comes to research, right? So your innovative work has really moved forward the science of exercise with LAM in ways that we could never have dreamed. So I thank you for that, not only as a woman with LAM, but also from the foundation. We just really appreciate the research and the work that you've done, and just all of your continued support for the LAM community on so many levels. So we look forward to celebrating the continued success of the LAMFit program. It's so exciting to see how it's growing and being built upon. So let's give a round of applause if you can. I know it's all silent for our speakers this evening. This was incredible. And we want to thank you both, and hope that you're able to enjoy the rest of your evening. So thank you so much for being here.
Thank you. And I want to add right back at you on the thank yous, because we could not have done this without the unbelievable participation of the LAM community. I mean, just anything we ask, immediately we've got people who are willing to give their opinion, give us their tissues, give us their pulmonary function, whatever we can get that from. So thank you back to everybody for all of your enthusiasm and generosity with giving. So thank you, and had a wonderful time. Thanks, everybody.
Thank you. We appreciate you guys. All right, take care.
Sure.
All right, so at this point, we are going to here. There we go. So we want to thank you all for participating in this evening's webinar. The video recording of this webinar will be available on our website. I would look for it right around that December 13th timeframe. So if you have other friends or people who weren't able to come tonight, please let them know. It will be available on our website. And at this point, we're going to stop our recording. And for those who are interested, please stay on, and we will begin our informal group session for anyone who would like to join us. So thank you all for being here, and have a good evening.